Is it visible?
Yes, sir.
I think the age of the patient I have wrongly typed. 350.
50.
And, so this is the challenges in these problems associated with morbid obesity, because here the BMI is not given, so you have to calculate it using the values that are given. So you have rightly done by converting the height given in feet and inches into centimeters, and then have made it into meter, and then squared the meter and divided it with the so what is the formula to calculate BMI for the sake of juniors or others who do not know about it? How do you calculate the BMI?
Weight in kg divided by height in meters per square.
Meter square. Very good. So height should be in meter square. And so this is roughly about 60 BMI. It is supermorbid obese as it was called earlier. But now WHO has classified only as class 3. So anything above 40 is called a class 3 BMI. What is important? How did this BMI come into concept? When was it introduced? What was the purpose of BMI? Did it come into the medical field to assess the problems of obesity, or was it introduced for some other purpose? Anyone can answer it. Yes, not coming out of
It was introduced for the purpose of sorting the military professionals, sir, to sort out who are the fittest and who are the weakest.
Pardon?
It was introduced for the purposes of filtering the military professionals to see who are the fittest and who are the weakest, or who are actually fit enough to be
answering. Kamal Pandian.
Yes, sir.
But I don't think that's the right answer. Any other answer for that? Was introduced for the life insurance purpose. When insurance was introduced, people who were very obese, soon after taking the insurance, many of them died at a very young age. And the insurance company have to pay a lot of compensation for them, or the insured amount. So they avoided giving insurance to people who are very obese by calculating the BMI. Beyond 35, they said we will not give you insurance unless you reduce your weight. Okay, for that purpose only it was introduced first in the insurance field, and then it was transferred to or utilized in the medical field to utilize for the purposes of the pathology of obesity is itself considered as a pathological state. It is not a pharmacological, it's a physiological state. And the second problem we have to know is the problems associated with robotic surgery in these cases. So once you know the challenges, the discussion should include these. These are common things which you have to include for all the cases. So if you remember in this order, you will be able to include or exclude some of the things which are not required, especially for long cases. But short cases, you can make it into a synapse and then go present it without, because in short case, they will directly go to the diagnosis and then ask a few questions in here and there. Again, it will be within this range only. So always better to practice your preparation in this order so that you will remember it better and your flow also will be easy. So history taking, what are all the important history you have to find out. So then examination of the patient, as you really do. Then what are the investigations that have been ordered already and what are the results you have. What is the risk stratification? How do you optimize if necessary, if there are comorbidities or drug intake, how to optimize the patient? And what are the pre-op instructions you have to give regarding You said this patient, you will have 10 hours of starvation. Is it required for 10 hours?
No, no, sir. 8 has, sir.
8 hours.
8 has.
Ah.
Protein.
Why 8 hours? The
Heavy
guidelines
solids.
for pre-op starvation is only 6 hours for solids. Is it given specially for the morbid obesity as 8 hours or 10 hours?
No, sir. No, sir.
Hmm?
No,
Okay.
sir.
So then this is because there are two problems here. One is morbid obesity, another is robotic surgery. So OT preparation and planning is very, very important. And then the plan of induction, maintenance, recovery, and post-op care. So these are the subheadings under which you have to plan your answer and also constantly practice presenting in this way. Now coming to the history, I have taken the diagnosis or indications for the partial nephrectomy as RCC, which is the commonest condition for which the surgery will be done. Isn't it?
Yes, sir.
Most commonly, it will be renal cell carcinoma. So, what are the history that we have to know pertaining to the RCC, which is relevant to you as an anesthetist? Not, I don't want the surgical importance of problems, but patients with RCC can be classified into two groups: symptomatic patients and asymptomatic patients. All of a sudden, a patient with RCC may come with a palpable mass with no pain, no hematuria. So they may be totally asymptomatic, or they may have symptoms, earliest of which will be hematuria. And if they have ignored this hematuria for quite some time, they are likely to become anemic. So the anemia will be a very important problem in these cases. So we must ask for history relating to anemia. What are all the common features of anemia will be there in the history?
Like
I have not given the
weakness, fatigability, palpitation.
fatigability, easy fatigability. That is a very, very important thing. Now here, if a patient is anemic and he is fatigable, and at the same time morbidly obese patient, how will you find out the fatigability? Because do you think the morbidly obese patient will be an active person like a normal BMI patient?
No.
No, they will be sedentary, mostly because of the weight, their movement will be very much restricted, isn't it? They may not be active like as you think. So fatigability will not be easily found out in these patients. That will be a confusing point. What is sarcopenic obesity?
Due to prolonged will be less, but the fat will be more.
Yeah.
Fat
So
accumulation.
very good. So if the muscle mass is less, how will you find out whether they are sarcopenic obesity?
Like,
what are the tests by which you can find out?
hand grip.
Very good. Then
Triceps.
Walking instability.
walking instability. Sedentary life. Okay, mostly they have their movement restricted. So all these things will indicate that their muscle power is also very poor. And if they have sarcopenic obesity, what is the effect on the respiratory system post-operatively?
The respiratory muscles will be weak, so they will
Fatigue.
go prone
With the pain, they will not be able to breathe adequately, and atelectasis and retention of secretion, post-op pneumonia are all very, very important complications. Okay, and these from the surgical point of view, anemia. Of course, weight loss, because it's a malignant condition, weight loss will not be very distinctly seen in a morbidly obese patient, but patient may still give a history that from 145 kg, they have lost about 5 kgs and become 140. That may be the small loss that they may have. Flank pain may be predominant in some cases, and some people would have felt the mass, or the surgeon would have told them that they have a mass. And night sweats or development of hypertension after the development of RCC is also very common, and the on and off fever for which there is no evidence of any infection. So all this history are very, very important. To rule out any associated infection, history of fever is also very important. And if the condition has been diagnosed and any immunosuppression or radiation has been given to reduce the mass before surgery, that treatment history is also very important. And whether there is any compromised renal function because of the RCC or the renal condition that is warranting a partial nephrectomy, that also can be elicited from the history. So that is how you elicit the history pertaining to RCC. Then pertaining to morbid obesity, possible cause of obesity, you rightly started off with, like familial, endocrine, or environmental, or genetic, as you say, which are all the genes which are responsible for obesity. Can you name a few genes which are responsible for obesity?
Ghrelin and leptin and ghrelin.
Ghrelin and
Lep-
leptin are satiety and hunger hormones. They don't come under the genetic category. They produce a pattern of eating. There are three genes that have been told. I will show you in the next presentation. So, and important thing in morbid obesity is OSA. The OSA can be present and identified, and already patient may be treating. So you may get a category of patients who have been diagnosed with OSA even before they come for surgery, and they may be using a mechanical ventilation like BiPAP or QPAP, or they may be suffering from it without knowing it, and they may be ignorant of it. You have to find out. In that case only, you have to use the top bank questionnaire or Berlin questionnaire for that. So there are two categories of OSA patients: diagnosed and already treated patients. Patients who have been suffering from OSA for a long time without knowing it, and the first time you find out. So the treatment modality is totally different here. So we have to go for a overnight polysomnography and then try to identify the severity of the OSA. And here the examiners may ask you all the questions about how to find out the severity using a polysomnography. How do you diagnose severity of OSA with the sleep study or the polysomnography testing?
Apnea, hypopnea index.
Okay, hypopnea index. How many categories you can classify?
Mild, moderate, and severe.
Mild, moderate, and severe. Okay, so based on that degree of hypopnea and total apnea index, you can find out the severity of what are all the treatments that can be offered for OSA? Is it straight away going for CPAP and BiPAP, or what are all the other modalities of treatment that can be offered? For mild category, what is the treatment that you will offer?
Positional sleep.
Positional. Positional, usually they themselves adapt to the lateral or prone positions. Most of the OSA patients, because they wake up with a startling because of the obstruction, over a period of time, they themselves try to adapt to the lateral position or prone position so that they don't wake up that frequently.
So for mild AHA index, we can go for weight loss like that, sir. Moderate.
Lifestyle modification. You can put
lifestyle.
them on one word that called lifestyle modification. Okay, what are all the lifestyle modifications you can do? One is weight loss, then
Smoking cessation, sir.
smoking or alcohol sedation.
Alcohol
More than
cessation.
smoking
Okay.
is alcohol or sedative or other narcotic drug usage. Then anything else? Breathing exercises. And get a ENT consult to see whether they have any mechanical obstruction like enlarged adenoid or pharyngeal problems. So that is the thing that you can do for mild cases. Moderate and severe definitely will require some of the assisted ventilation like CPAP or BiPAP. What is DICE?
Drug-induced sleep
Drug-induced
endoscopy.
sleep endoscopy.
Endoscopy. Okay, so that also can be asked in this particular situation. So what do you do in this DICE?
We'll give a mild sedation and we'll look at the desaturation. By endoscopy, we'll look at whether there is a tongue fall, any obstruction is there or not. We'll look into it.
DICE
And
is done to locate the exact site of obstruction. Okay, it can be the pharyngeal wall, it can be nasopharynx, it can be oropharynx, it can be tongue. Okay, so DICE is a method or an investigative procedure to identify the exact location of obstruction that is happening in obstructive sleep. So these are all the supplementary questions that you have to be ready to answer with about. And how do you do the OSA testing?
the patient should be admitted before day, and the sleep should be videographed, like ECG, O2 saturation, EMG. Muscle, like strap should be placed to look at the respiratory movements.
Their breathing, noise, or sound to be recorded.
Yes, sir.
And they require a phonogram.
Yes, sir.
The snoring noise should be recorded. The obstruction and the apnea should be
The lowest
recorded.
SpO2 should be
So
possible.
there are 7-8 monitors that are attached to the patient, and the room should be adequately dark enough to sleep. And patient can lie in whatever position is comfortable, and you record the whole thing overnight. But nowadays, due to want of time, in order to avoid that only, we have gone for the DICE, which it takes only about 10 minutes time. So instead of overnight sonography, DICE is becoming more popular to identify the anatomical site of obstruction, and that is the reason it's being done more commonly. And so these are the things that you have to know about. And with regard to comorbidities, these are the common comorbidities that may be present in them: diabetes, coronary artery disease, asthma. Thyroid is a very important thing which you should not forget, because the whole obesity may be because of hypothyroid. But of course, all the clinical presentations will be right, the dry skin. What are all the features of hypothyroidism?
Weight gain, amenorrhea, heat intolerance.
Appearance wise, patient himself, they will
Weight
come
gain.
to what are all the complaints which
Dull
the patient will come at?
staring look.
Weight gain, sir. Increased
Weight gain, dry
Weight
skin,
gain,
and
easy
hair loss.
fatigability
Especially females will be more worried about the hair loss. So
and
weight gain,
menorrhagia.
dry skin, and heat, I mean, cold
Cold
intolerance
intolerance.
and constipation. Was all of these things, you know. So be wary of this particular complication, which can be the cause for hypothyroidism. And GERD history is very, very important to know whether there is a chance of regurgitation and aspiration. And cortisol related, I have made a point here that it can be endogenous or exogenous. Why? Why these two categories I have given here? When will you have an endogenous increase in cortisol? When will you have exogenous increase of cortisol?
Steroidal intake exogenous and pushing endogenous.
Cushing's will have endogenous cortisol level because it's an endocrine disorder. Cortisol levels may be high. The patient is also suffering from Cushing's disease, which again can be the cause for the obesity. On the contrary, patients who have the joint and body pain, musculoskeletal disorder because of obesity, they may be given some steroids to suppress the pain. So exogenous intake of steroids also could be contributing to that. So that is also a very important to see whether they have taken any steroids is very important question that you have to ask. And in this class, category of class 3, obese patients, effort tolerance. You have to ask whether they are able to attend to their nature's call and having their bath and other things without any assistance, or they need assistance for all these things. How far what is the maximum distance they can walk? And so to rule out any sarcopenic obesity, you must ask for this particular history of effort tolerance. And musculoskeletal with regard to positioning. So at a particular position, they may have a knee pain or a hip pain or a back pain. So while positioning the patient, if you have taken the history and noted down the musculoskeletal problems, you can avoid worsening of that particular pain in the post-op by noting down this history. And this is a very important history. I have put it here, METS. What is that?
Metabolic
It's a
Metabolic syndrome.
metabolic syndrome. Okay, this metabolic syndrome, you have to always, the acronym is written like this: capital M, small e, P, and a capital S. This means metabolic syndrome. If you write all the letters in capital, E, T, S, all in capital, that goes to the metabolic equivalent to assess the effort tolerance. So remember, my important thing is MET written in capital with two small letters followed by capital indicates metabolic syndrome. What is this metabolic syndrome?
Base circumference more than 103, diabetes mellitus, hypertension, HDL is less than 40, and triglycerides more than 150 will be that. Pepintian syndrome is a genetic syndrome.
3 out of 5, it is there.
Metabolic syndrome is a group of presentations present in obese patients, where under which you say these are the first and foremost is the waist circumference, then hypertension, then hyperlipidemia, then diabetes mellitus. Out of 4, any 3 present, you call them as metabolic syndrome patients or syndrome X. Okay, the other name for that is the syndrome X. So the importance of this, why this abdominal circumference is taken as an important criteria?
Central
To the
cardiovascular.
What is the cause of this abnormal waist circumference increase in metabolic syndrome? Is it the fat that is accumulating around the abdominal wall, or something else also contributes to that?
Lipoprotein lipase. Produced by lipoprotein lipase, which is produced by omentum, which is a risk for metabolic.
Omental increase in size. Okay, they have enormous increase in. Supposing you do a laparotomy in a patient with metabolic syndrome, you will find the omentum will be heavily studded with fat. Okay, it will be huge, almost 3-4 kgs of weight will be in the omentum, which is normally very thin. So there you have this lipase, which is a very active and produce a lot of inflammatory reactions. And that is the reason why this possibility of sudden death in patients with metabolic syndrome is very, very common. So you have to look for features or ask for features, whether their abdomen has been growing bigger and they have finding it difficult for men to wear pants. They have to frequently change the size of the pant, or women, they find it difficult to tie the sari around and all that. So rule out metabolic syndrome in all morbid obese patients is a very important point you should not forget. And any previous surgery and whether there have been any complications is a very important history that you have to elicit. Lastly, but not least, it's a very important thing. They may have history of depression and psychiatric treatment. All morbid obese patients, many of them go into depression because of the inability to move like others, or they are very conscious about their looks, and so that produces a lot of mental depression. They may be undergoing psychiatric treatment and taking drugs for that. So this history should not be forgotten. So these are the important histories that we can divide into the two conditions. Now coming to the next point of examination, again that can be divided into pertaining to renal condition, like whether looking for any anemia or palpable mass, or sometimes even in a early stage, late stages of the, if it is a renal cell carcinoma, metastatic lesions may be there present in all the other organs, like especially if it has gone into the lung, patient may have a chronic cough. So examine for all these things with regard to the primary complaint with which the patient has come. Now coming to the examination pertaining to obesity, first always give priority to airway. That is a very important answer that is expected in the examination. So because airway problems are the important problems which cause a lot of mortality and morbidity, especially in class 2 or 3 airway obese patients. So first and foremost, examination of the airway to assess the airway. And of course, naturally, vascular access may be very difficult in these patients. So look for the ideal site and features of metabolic syndrome that also you have to examine. The features of OSA, whether patients have pulmonary hypertension. Is it possible to find out pulmonary hypertension clinically? Supposing patient has been having a long-standing OSA which has not been properly attended or treated, and if they develop pulmonary hypertension, is it possible to find out pulmonary hypertension by auscultation? They will have a loud P2. So if you carefully auscultate over the pulmonary area, P2 will be quite loud and strong. So that is a very easy way of identifying pulmonary hypertension clinically. And features of right heart failure can have parasternal heave in the right side, and if they have SVT, that is systemic hypertension, and if they have gone in for left ventricular failure and neglected OSA producing right heart enlargement and failure, they may have features of biventricular failure. And Pickwickian syndrome, especially class 3 obesity, what are the features of this Pickwickian syndrome?
Metabolic syndrome.
Huh?
Obesity, hyperventilation syndrome.
It is otherwise called obesity hypoventilation syndrome. Okay? So why this name Pickwickian syndrome? Who
The
gave the
patient
name
will be
Pickwickian? Huh?
hypercapnic even when awake also, sir. So
Pardon?
they are not big. The patient will be hypercapnic even in awake also, sir.
No, I'm not asking the features. Why this name Pickwickian syndrome has been given? Okay, try to find out and tell me by the end of the class, or I'll tell you the answer. Okay? And then cardiac features like LVH, systemic hypertension, any features of coronary artery disease like anginal pain or identified by ECG. And respiratory system, always look for wheezing because many morbidly obese patients are also asthmatics. So they may have a wheeze, and check or examine for the breath holding. So breath holding, because why their breath holding is likely to be low?
Due to
Due to
obesity, sir, the abdominal like the chest wall get compressed and there will be low FRC.
Low FRC, that is the answer. Don't worry about the abdominal wall and all that. FRC is low. I have told you in the other class, conditions causing reduction in FRC, pangos, mnemonic. What are all the things for pangos? PANGOS.
Pregnancy,
Ascites,
ascites,
neonates,
neonates,
geriatric,
not geriatric, GA,
general
obesity,
anesthesia,
and surgery in the upper
GA.
abdomen. Okay, pangos, PANGOS, 6 letters. P for pregnancy, A for ascites, N for neonate, G for general anesthesia, O for obesity, and S for surgery in the upper abdomen. These are the conditions which cause reduction in FRC. So breath holding will be low because their FRC is low. And always check their room air saturation. Some of them are chronically hypoxic. So that room air saturation will be low. So that also has to be examined. Now coming to the investigations. Investigations can be common to, of course, all the investigations relevant to surgical condition would have been done by the surgeon and then will be presented to you. But from your point of view, do a thorough cardiac evaluation. And then for respiratory, especially if OSA has not been detected earlier, polysomnography and the test pertaining to comorbidities and their present status. These are the investigations that are required. Now, optimization, you have to optimize the cardiac condition. If there is anemia, you have to correct that. OSA can be corrected with CPAP and BiPAP. And planning and briefing. This particular case scenario, this may not be a routine in all our cases, but in this particular case, you have to do this planning and briefing. Briefing to the entire team which is going to handle this patient, very, very important. So you must start from talking to the surgeon, then you must talk to the OT people, then you must talk to the ward managers and trolley, the stretcher bearers, everybody to put the patient to OT with appropriate trolley or wheelchair. Or sometimes if the patient is ambulant, you can, and the theatre is nearby, you can even ask the patient to walk because sometimes you may not have an appropriate transport vehicle. And then you must discuss and see whether you can position the patient properly on the OT table and check whether all the equipments to hold the patient securely in the table, because the surgery is not going to be done in the supine position. It's going to be done in the lateral position. So you must have adequate personnel to shift the patient after anesthetizing. It's very difficult. So you have to make sure that you have adequate personnel and support to shift the patient. And once you position them, you must have proper equipment to hold them in that particular position without sliding or falling out of the table. So just to give you a visual impression, see here this patient's belly is so huge, and to support that they have put another additional attachment to the operating table. And what is this white things that have been given here?
Compression
legs.
stockings. Robotic
This is
stockings.
the head stockings or the compression devices, which are very important because these people are likely to develop DVT. So all the precautions for preventing a DVT is routinely applied in these patients, and see how much of strapping and binding is given. And another case where again to show where are all the ports will be done for this particular surgery. And this one, what is this port? Is it a port or it looks like a bigger incision?
Incision to remove the kidney.
This is the delivery, specimen delivery incision. Okay, these 2, 3, 4, 5 are all ports for the robotic arms introduction. Okay, so just to, for those who have not seen or had a chance to see the surgery, I will just put this picture so that you will get a mental idea how to do that. And so next thing comes is the plan to secure the airway. So there are two options based on your assessment of airway, whether it can be manageable airway or it is going to be an anticipated difficult airway. These are the two categories that you can make out of the airway. So if it is if you think the mouth opening is adequate, Malambati is only 2, and the extension is adequate, it is not a short neck despite being a BMI of 60, you think you can manage, then you can go for the conventional technique. But here you must definitely have a ramp position to have a smooth laryngoscopy and intubation, and then adequate pre-oxygenation should be available. and you can go for your regular IV injection. You can paralyze the patient with muscle relaxant, do a laryngoscopy, intubate as you do in a regular way. So this also has to be planned. On the contrary, if you anticipate difficulty, the neck movement is very restricted or very short neck, mouth opening is also, uh, of course, the Malambati scoring is 3 or 4, then what do you do in that cases?
I'll go for awake fiber optics.
Very good. So if it is anticipated difficult airway, that safer we go for awake oral fiber optic assisted intubation under topical anesthesia. So these two things have to be decided and documented in your pre-anesthetic record so that it will be conveyed. If you are not going to be the anesthetist, you just do the assessment and someone else is going to anesthetize, then they should know that they should get the FOB ready, and people who are trained in that should be available, and patients should be counseled, and consent should be got, and everything to be explained to the patient. All the preparations for capitalize the airway and monitor it should be done, and it should be planned well in advance. Then comes the placement of monitors. This also has to be planned in advance. So whether you can use NIBP for this case, if you have the extra large cuff which can be applied to the arm, you can use and do an NIBP. But if such large cuff is not available, what to do? Yeah, only
Actually,
the
can we
standard.
place?
Huh?
We can place the cup over the forearm. Sir,
You can use
actually,
the cuff on the forearm below the elbow, record the blood pressure on the forearm also. So it is not contraindicated. But in case it's good, if you anticipate any major blood loss or any difficulty surgery after discussion with the surgery, better to go for a arterial line which will help you to beat blood pressure, as well as what is the other advantage of arterial line?
ABG sampling.
You can take samples without puncturing the patient again and again. Good. And you can do CVP under ultrasound guidance if necessary. If you don't have a proper peripheral vein, you give drugs other than the fluids, then you can go for a CVP. Temperature monitoring is very, very important. Why these people are likely are prone to become hypothermic?
Large body surface area, sir.
Large body surface, excellent. So radiation loss will be very high, so they will become hypothermic. So proper care to preserve the temperature is very, very important. Urine output is monitoring is also very important for two reasons. Why?
Kidney procedure. Like
Because it's a renal mass, so we do not know the existing renal function. So unless you monitor the output, you cannot pick up a acute kidney injury or acute shutdown. So always you must have a urine output monitor. CO2 and SpO2 monitors are very important to routinely see the ventilation, EKG, and the end-tidal gases and volatile measurements if you are going to use inhalation agents and general anesthesia. Or if you plan for FIVA, you have to have a BIS monitor to assess the depth of anesthesia. So these are all the important preparations that you have to do. And these are all just the symptom-wise involvement, RSA, OSA, hypoventilation syndrome, restrictive lung disease, asthma. These are the previous involvement. Endocrine metabolic syndrome takes a cake, so you have to always look for this. And GI, non-alcoholic steatohepatitis, hiatus hernia, gallstones, and musculoskeletals, OA, backache, hernia, and malignancy other than this, and renal failure, depression, and sex expectancy or other things that you have to remember. Now, what are the anesthetic challenges of robotic assisted surgery? So that is the second half of the challenge that you have to face. And these are all the common challenges that they give you. One is general considerations as you do in any surgery. Second important thing is the lack of access to the patient. whether it is lateral position nephrectomy or steep Trendelenburg position for radical prostatectomy, etc. Whichever be the surgery, access is a challenging thing for you. So better to secure your IV line position and monitors everything well before you position the patient and give the patient to surgeon to dock it, so-called introduction of all the arms of the robot. And of course, steep Trendelenburg will not be applicable here. Pneumoperitoneum and its consequences. Here also, just like your laparoscopy, we introduce CO2 insufflation is done. So, what are the effects of CO2 insufflation? What especially cardiovascular response to CO2 insufflation in pneumoperitoneum, creating pneumoperitoneum?
During inflation, due to the stretching of the peritoneum, and that can be bradycardia and can go for RS.
Go for
RS. Bradycardia and asystole.
asystole. How many cases of asystole have you seen after insufflation? It is not direct puncture and you are not producing a carbon dioxide embolism. I am asking you the general physiological changes or response to pneumoperitoneum. The commonly in all cases where you do create a pneumoperitoneum using carbon dioxide. Do every case go into error?
No, sir. No, sir.
And they won't be doing the surgery at all.
So, in due to pneumoperitoneum, that respiratory, that will be ventilator perfusion mismatch, sir. Peak RV pressure will be raised, hypercardia, tracheal tube displacement will be there, and that can be cerebral edema, facial edema, and cardiovascular system increase oxygen consumption, risk of air or venous air embolism, sir. Vascular injury can occur.
I'm not asking about the risk of doing the needle insertion and everything. I'm asking that normal cardiovascular response to creating a carbon dioxide carboperitoneum. That's what I'm asking. What are all the phases? See, you are introducing carbon dioxide into the peritoneal cavity. Isn't it?
Yes. Yes, sir.
So what will happen to the carbon dioxide? It will lift the abdominal wall, create more space for the surgeon to go and approach or they reach the organs that they want to operate. But
Yes.
this carbon dioxide, is it easily absorbed into the patient's circulation or not?
Yes, sir.
It can get absorbed into the circulation. So EtCO2 value, what will happen as soon as they start doing the
It will rise.
Rise in age.
from the normal level, it will start going up. What are all the effects of accumulation of CO2 in the blood? System will be
Tachycardia.
stimulated. Sympathetic stimulation will happen. Isn't it? So patient will have tachycardia, hypertension. Okay, that is what I am asking. So these are the initial things that you expect. So in a patient with already existing hypertension or a coronary artery disease, is it advisable to have this tachycardia and hypertension because of the accumulation of CO2?
Oh, sir.
No. So how do you manage that? What are all the strategies to avoid the ill effects of carboperitoneum on the cardiovascular system?
Pressure should be kept.
So insufflation
Pressure.
rate and pressure should be monitored and kept at an advisable or a safe level. Just 10-14 millimeters of mercury. And how many liters per minute? Less than how many liters per minute can be insufflated?
6 liters.
6 liters.
So that is the first and foremost thing. Hydrogenically, we should not rapidly insufflate the abdomen. Right. Then that is preventive measure. But in spite of that, once you insufflate, it will definitely get absorbed. So what are all the methods to prevent that tachycardia and hypertension?
Ventilation.
You can do it by respiratory strategies or pharmacological strategies. That is how you classify the answer. What are the pharmacological strategies you can first you try respiratory strategies. If it does not respond, you go to pharmacological strategy. What is the respiratory strategy you can follow?
Increase the respiratory rate.
You hyperventilate. You wash out that carbon dioxide. What is hyperventilation? How do you define hyperventilation?
Tidal volume more than minute to increase the minute
No,
ventilation.
I'm not asking you the settings. I'm asking the definition for the word hyperventilation. When will you say that you are a patient or you are purposely hyperventilating?
Normal respirations are up to 16 per minute, 16 breaths per minute. We are increasing the respiratory rate and excessively
I think you are
ventilating.
not understanding my question. I'm asking a simple definition of hyperventilation. So forget about this case scenario at all.
Abnormally
Huh?
rapid or
Increase in
abnormally
alveolar
rapid or deep
ventilation.
rate.
Abnormally rapid increase or
The basal metabolic needs.
anyone who can give me the correct definition of hyperventilation? Hyperventilation is defined as increase in rate and depth of respiration resulting in washout or decrease in the blood carbon dioxide level. That is what is called hyperventilation. Increase in respiratory rate as well as depth resulting in decrease in blood CO2 level is called hyperventilation. When will you physiologically do hyperventilation?
Pain.
During
During
exercise. Pain is pathological.
Yes, sir.
Physiological is exercise. Whenever a person walks or runs or jogs, then you hyperventilate automatically. Why nature has made you to hyperventilate during exercise?
Increase oxygen, sir.
Increase in
Oxygen.
oxygen demand is increased. Metabolic activity, what does it produce? See, whenever your muscles are working faster than normal at rest, what is the ultimate end product of that activity?
ATP production. Carbon dioxide.
ATP production, everything results in CO2.
Carbon dioxide.
More energy is utilized, more as long as oxygen is available, it will be mitochondrial oxidative phosphorylation. So more carbon dioxide and water will be produced. That carbon dioxide has to be eliminated. See, nature is such a beautiful adapter of all our activities. So it is able to give you more oxygen by hyperventilation. At the same time, it can remove the excess carbon dioxide that is produced by your increased metabolic activity. Right? So physiologically, every person doing a vigorous exercise hyperventilates. Pathologically, whenever there is a pain, you hyperventilate. Why? Is it because there is an increased metabolic activity?
Sympathetic.
And you fall down or you have a fracture, you sustain a trauma. At the time, is your metabolic activity increased?
Yes, sir.
Immediately, is it? Yes, sir. Such a strong and powerful answer. You are feeling the pain. So, how does pain creating hyperventilation helps? Because again, as per the definition, what did I say? Increase in the rate and depth of ventilation resulting in reduction in CO2. Whenever there is a reduction in CO2, what will happen to the pain perception or pain threshold? It will increase. Pain threshold will increase. Pain perception will come down. So that is again another nature's adaptation. So automatically all of us say, do that just to reduce the intensity of pain. That is the nature's way of giving a natural relief. That is the second thing. And in anesthesia, we do it purposely in some conditions. Again, I have got an ASCII on that, so I don't want to tell that answer. Okay. So the pneumoperitoneum can be managed by temporary hyperventilation by increasing the rate as well as the tidal volume. Okay. And what other adaptation you have to do? apart from raising the tidal volume and rate, what other adjustment you have to do in the ventilator?
IE ratio.
IE ratio, fantastic. You have to give a prolonged time for expiration to wash out the carbon dioxide. So instead of 1:2, you keep 1:3 or even 1:4, so enough carbon dioxide will be washed out during the expiration. These three adaptations you have to make. Increase the rate, increase the TV, increase the IE ratio. So by doing this, you can temporarily manage until the CO2 stabilizes at a particular rate. What are all the strategies that you can do to reduce the blood pressure and heart rate, which is the result of CO2 accumulation in the cardiovascular system?
Adequate depth. Vasodilators.
So dilator, right? You must tell me the drug that you use.
Yeah.
Theaterla poi vasodilator will not produce the effect, isn't it? Or drug you have to give, or dose you have to give.
Injection nitroglycerin, sir. Infusion.
Nitroglycerin. Any other drug can be given before the introduction of pneumoperitoneum, which will totally avoid the rise in this heart rate and blood pressure.
Beta blockers.
Beta blocker. Any other better drug, which will also have some analgesia.
Magnesium.
Magnesium. Magnesium, does it produce reduction in heart rate also? May reduce the BP, I agree. But will it cause a reduction in heart rate?
No, sir.
A drug which you are
Dexmedetomidine.
using every day. Dexmedetomidine. Yes, Artemin or clonidine or dexmedetomidine is ideally recommended for this particular thing. After laparoscopy became quite common day-to-day surgery, the introduction of dexmedetomidine has become a very great boon to reduce the occurrence of tachycardia and hypertension, especially if you give it as a preemptive manner before the introduction of CO2, then a proper dose of dexmedetomidine will take care of the effect of this carboperitonium producing tachycardia and hypertension. Okay, right. So these are the things that you have to know about the pneumoperitoneum component. Of course, maintenance of body temperature we have already said. Fluid management, especially in this robotic surgery, they say you have to go for goal-directed fluid therapy is an ideal way, but in case if you are not able to do that, why goal-directed fluid therapy is a challenging thing? Cannot be done in all cases. What is the reason?
Request increase equipments.
You require equipment
Invasive
like
monitors.
the monitor or the FPV monitor. So it is a costly affair. You require a proper monitor to do the management in those cases. Okay. So such incidences, it is better to go for restricted fluid therapy. And fluid is always calculated on lean body mass and not on the so-called ideal body mass. Okay. So the lean body mass, ideal body mass, total body mass, or weight, all these things are very important terminologies which you have to remember in obesity patients, which will be asked. And pain management, better to go for always say multimodal analgesia. That is the Taraka mantra for pain management in any case nowadays. So avoid narcotic-based pain management, especially morbid obese patient of class 3. And teamwork and communication, which I have told, prepare for complications like unexpected bleeding or conversion from robotic to open. And of course, the upper body edema is a more common complication in steep Trendelenburg position, will result in pharyngeal eye and cerebral edema. It is not that much of an hazard in lateral position than for nephrectomy. And postoperative visual loss, again more common in the steep position. The nerve injuries and soft tissue injuries. These are very important, especially in lateral position. When you affect the arm and then affect the injury or the injury, all these things are very common, so they have to be taken care of. And cardiopulmonary compromise patients who are healthy as well as who already have some problem. And creating a pneumoperitoneum, the gas can go into thorax or megastainum, producing air entry into all these things, producing pneumothorax or megastainum. And introduction directly into the vascular system, producing carbon dioxide embolism. Hypothermia, of course, is getting a repetition of that. Blood loss, all these things are the general problems in the robotic. Now, what are the contraindications to robotic surgery? The chest and abdominal cavity. The surgeon says that they want to do robotic excision of the tumor. You'll have to go in for the conditions, whether their indications are right or wrong. So, first and foremost itself is a severe obesity. So, patients who are morbidly obese, they are not suitable candidates for robotic surgery. If they have glaucoma, so you have to ask about history of glaucoma also. Patients who are likely to undergo robotic surgery, and increased intracranial pressure, abnormal kidney function, patients with severe pulmonary hypertension. So long-standing OSA patients not treated properly, they may have severe pulmonary hypertension, and suspected multiple fluor adhesions, recent myocardial infarction or already stable coronary disease, norpulmonale, patients who have asthma or COPD, or relative contraindications for robotic surgery. So these are the things that we have to keep in mind. This is the actual way in which all the ports are done, and this will be the picture that we will see in the monitor. This is how all the arms of the robo are top. You can see this is how patient is in the lateral position. All the cameras and are all inserted into that. The surgeon sits at a far away patient. These are all assistants who are standing close by, and they are just standing with their arms folded. They are not doing anything because it is all controlled by the surgeon who is sitting at the so-called console and operating. It's like playing a video game. Like that, they sit there and do. These people only will do some adjustment, taking out pick up something, put a suture inside, all the things are done by that, but the rest of the things are all done by these three arms that are introduced. Okay. So what is the advantage claimed by the robotic technique?
It is
Important
less
one.
pain,
Huh?
less pain, minimal bleeding.
No, surgically, from the surgeon's aspect, what is the advantage they claim?
Like
It
higher
will be 3D
and
images.
minimal
It is more
tremors.
precise, okay? And it has a
Fine
3D
movements.
view, and it can reach into the crevices and small cavities. Like especially when they do the prosthetic surgery, they can go into the deeper areas of pelvis and do that. These are all the points that we have to look at. And stopping this, I am showing you another presentation on obesity by itself. Visible?
Yes, sir.
Okay. So I'll just go through another presentation on purely on obesity and anesthesia, because this is a more common topic more than your robotic things. They just combine both because robotic surgeries are being done more frequently nowadays in many hospitals. So I thought I will combine both. But purely obesity, these are all the subheadings under which we will be dealing with. And definition of obesity is it's an abnormally high amount of adipose tissue compared to lean muscle mass. And the comorbidities that are usually found are, of course, this is the slide I showed earlier. And the pathophysiology or causes are basically BMI, imbalance between energy intake and energy expenditure. So we eat more, work less. That is the reason mainly for acquired obesity. This is not the reason for genetic or endocrine obesity. For acquired obesity, this is the main reason. Fat storage happens as triglycerides in many patients when they don't exercise properly. And types of obesity, the examiners sometimes ask you. One is called the abdominal or android obesity, and the peripheral or gynecoid obesity. And this is where the waist to hip ratio more than 1 in male and than 0.8 in female is a risk factor for ischemic heart disease, stroke, DM, and sudden death. So that is the reason why you have to know about the pattern of fat distribution, mainly the android type and gynecoid type. And stress and cigarette smoking stimulate cortisol production, which may also enhance deposition of abdominal fat. So whenever you find a patient with metabolic syndrome with increased abdominal girth, smoking and alcohol consumption and stress has to be avoided by lifestyle modification. Now coming to the pathophysiology, cellular disturbances, usually fatty infiltration of pancreas, which causes insulin resistance. So that leads to increase in monocyte size, increase in cytokines like interleukin 6 and 3 alpha, secretion of uh, uh, called adiponectin, which is a sensitizer of insulin. So this sensitization of adiponectin comes down. So that is why they develop type 2 diabetes mellitus, even in younger ages if they are obese. And that is the pathophysiology which can be asked. And adipocytes, they are responsible for secreting these two hormones like leptin and ghrelin. So leptin is an hormone of satiety. So whenever we eat, we know I am full. I can't eat anymore. That feeling is given by this hormone leptin, and it activates monocytes, which decrease the capacity of neutrophils. And hormone for hunger is ghrelin, which modulates appetite. So in patients who are uh, gluttons to eat more, the ghrelin production is high. So they don't feel satisfied at all. They keep on eating. Whatever excess eating is done, that all gets deposited to produce obesity. And the genes which are important for genetic factor causing obesity are the beta 3 adrenergic receptor gene, then peroxisome proliferator activated receptor gamma 2 gene, chromosome 10p, and melanocortin 4 receptor gene. These are the 4 genes which are responsible for genetic contribution and pathogenesis of obesity. And mutations in these two hormones secretions also lead to the particular problem. And environmental factors, increase in calorific intake and decrease in physical activity, said earlier, and psychological and socio-economic factors, binge eating disorders, night eating syndrome, especially among the IT people who work for especially United States timings. They all go to work at 7 p.m. and then come back home at 5 a.m. or 6 a.m. and keep awake through the entire night. And their breakfast starts at 9 p.m. Their lunch is at 1 a.m. Their evening snacks is at 6 a.m. So that sort of eating habits get different. So they all put on weight. and this also leads to depression, and the marketing strategies of producing large sized food packets that also leads to this particular problem. And what are all the anthropometric measurements you do in obesity? That is ideal body weight, also known as Broca's index. And this is normally calculated. Of course, this is a very simple formula to calculate it. Height in centimeters minus 100 for men and 105 for women. But there is a bigger correct calculation which I'll show you later. And BMI is also known as Quicklets index, where you calculate it by weight in kilogram and height in meter square. And lean body mass is supposed to be ideal body weight plus 20% of the ideal body weight is considered as lean body mass, which is purely the weight of the muscles and the organs like liver, spleen, etc., and doesn't include the body fat. Then the fourth measurement is waist circumference, more than 102 in male and 88 in female, and waist to hip ratio to assess the complications. Then tricep skin fold using this what is called the Harpent and calipers, and criteria for diagnosing metabolic syndrome. This is a commonly asked question. Abdominal obesity, hyperlipidemia in the form of triglyceride, high density lipoprotein cholesterol, presence of hypertension, and fasting glucose more than 110 or a pre-diabetic state. All these things. Out of these 5 criteria, if any 3 if they are present, that person has to be branded as patient suffering from metabolic syndrome. And then the World Health Organization, obesity is a grade. These are all the things. And automatically, once a patient belongs to class 3 obesity with a BMI of more than 40, they automatically fall into the ASA 3 category, whether they have coronary artery disease or asthma or not. Even if they don't have any comorbidity, class 3 itself qualifies them for being called as ASA 3 category patient. And adipose tissue distribution can be assessed by CT MRI also. And this is the definition of sarcopenic obesity, where reduced muscle mass and functional capacity happens in the presence of obesity, and that can be clinically diagnosed by poor food strength, history of immobility, and slow gait. And preoperative risk assessment, which I have not told in the earlier discussion, central or peripheral fat distribution, presence of metabolic syndrome, and peripheral oxygen saturation less than 95% breathing air. These are all risk factors. And the emergency medication you have to give in these patients like noradrenaline, dosing according to ideal body weight and not on the total body weight. And dose of atropine also has to be given according to lean body weight only. Now, this obesity surgery and mortality risk score, this is used for assessing the preoperative risk, where BMI more than 50 has 1 point, male patient carry risk is 1 point, hypertension 1 point, and age more than 45 1 point, and previous thromboembolism or venous thromboembolic incidences carry 1 point. So based on that, you can classify the risk involved in these patients also. And this morbidly obese patient or class 3 patients, they have to, the preparation you have to have their dignity preserved in the form of proper theatre gowns, because these patients, if they are given the OT gowns, it may not suit them properly. So make sure that these are all the things which will come in the planning, so that they are properly covered and their dignity is preserved. And deep vein thrombosis should be assessed, and all prophylactic measures should be taken. And while moving the patient, appropriate equipment should be available, which, as I told you, availability of chairs, trolleys, beds, operating tables, etc. Whenever possible, patients should maintain their own mobility. Wherever they can walk, they can be asked to walk, so that they are not Even if you don't have proper personnel, patient can themselves walk and POP. And gel pad should be used to protect pressure points. And the absence of any risk factors, RSI is not routinely required. Earlier, they were insisting that all obese patients, especially with abdominal obesity, they have the risk of regurgitation and aspiration. And if you are planning for a routine induction, paralysis, and intubation, it should be always a rapid sequence intubation. But in the absence of, if they don't have history of GERD, you can always do an ultrasound assessment of the gastric volume. And if that is not going to be risky, you can always go for a regular induction without RSA. And pre-oxygenation is very important in this issue because they rapidly desaturate because of low FRC. So there are several methods of doing it. Either it can be with head up position, 55 degrees, that is the RAM position is very important. And you can continue oxygen supplementation with the nasopharyngeal supplementation, 10 French catheter at 5 liters per minute. And you can apply 10 centimeter peak during pre-oxygenation itself, or reduce the occurrence of atelectasis by maintaining inspiratory pressure of 55 centimeters for 10 seconds after the institution of peak. So these are all some of the modifications and pre-oxygenation that the journal may ask you. And pre-anesthetic medication, usually we avoid all narcotics. You can give preemptive nausea, vomiting preventing drugs like dexamethasone combined with ondansetron or haloperidol. And pregabalin, gabapentin, and melatonin can be used as a prophylaxis for post-operative pain relief as a preemptive analgesia. And PET stockings and low-dose subcutaneous and fractional heparin can be given for post-surgical DVT prevention. And oral benzodiazepine considered for relieving surgery-related anxiety, but not parental. Okay, so you can give alprazolam or alprazolam tablets for relieving anxiety, but avoid uh, narcotics as much as possible. Prophylactic antibiotic therapy is very, very important to prevent surgical site infection. These are all some of the examples of this ghastly obese patients who are doing. And this picture, can you tell me what is this lady doing?
Making the
It's calculating the Taufir's lines. It's
Madam?
showing
Usually, obese patients, if you want to do a regional central neurasthenic blockade, the fat will be so overflowing, obscuring the midline. You cannot see the depression at all. It will be flowing all the sides. So here, the patient herself is asked to pull the fat by pushing it forward, so that the central midline is exposed very well. So remember, this point is especially Uji, when you want to give a spinal in obese pregnant woman, you can ask the woman to push the sides with a folded fist forward, so that the fat will be stretched out and you can see the midline and palpate that. Okay? So that will be easy. So these are all how they have been restricted. And OSA, very important, the commonly asked question. And stop bank questionnaire only to identify the condition. It is not as a routine you ask. If the patient has not been diagnosed with OSA earlier, you can identify whether they have that problem or not by asking this stop bank questionnaire. Okay. And the classification of OSA, it can be central and peripheral. So usually the central causes are stroke, drug, alcoholism, etc. And peripheral is usually the obesity. And investigations needed if undiagnosed or patients who are not aware, it is overnight polysomnography, where and other investigations are CBT, ECG, etc. And initial treatment is lifestyle modification like weight, we've already discussed, and then What are the surgeries that can be recommended for treatment of severe OSA?
Uvio palato.
You can resect part of the soft palate. You can do a tonsillectomy. You have to create more space in the pharynx. That is the common location where obstruction will happen. So normally they do a palatoplasty or tonsillectomy, adenoidectomy. All these are the surgeries that are done. Okay. Anesthetic risk, they are sensitive to narcotics. They desaturate easily. The long-standing OSA patients will develop biventricular failure because of both right and left heart problems. And these are all the expansions for stop and questionnaire. And there is uh, another method of assessing is effort sleepiness scale, which I recently had to use for a patient for a test surgery with a termination plan. And the score was almost 40, and nobody identified that the patient had a OSA. So this effort sleepiness scale was used. We could identify the OSA and put him on proper treatment. And, this is the Berlin questionnaire, which is an alternative to stop bank questionnaire, where again the same components of the stop bank are taken into consideration, divided into three categories. Category 1 is mainly all about the snoring habit, and the category 2 is about they're feeling tired in the morning because of lack of adequate sleep and the complications of that. And the category 3 is whether they have developed high blood pressure because of that. So out of the four components in the stop, snoring, tiredness, obstruction, and pressure, the three are categorized here to category 1, 2, and 3, and that is called the Berlin questionnaire. And airway management is a very problematic thing in obese patients. So if you anticipate difficulty, you must take extra measures to increase the safe apnea period. I think we have discussed or defined what is safe apnea period, which is the time between muscle paralysis and critical desaturation. Saturation going below 85, called critical desaturation. So that time has to be prolonged by normally in a healthy patient it is about 8 to 10 minutes, but in obese patient it will be as low as 2 to 3 minutes. So within the time they will start desaturating. So you have to take care of that. And the duration of safe apnea period can be increased for allowing you to do more, take more time to succeed in your intubation. And OSA is a daytime somnolence. Patients who feel sleepy during daytime, if both are present, it is called OSA syndrome. And this is another important category of discussion that may be happening in the exam: obesity and drug dosing. So you see the drugs are often they need an adjustment in obese patients, because drug clearance is mainly done by the lean body mass, not by the fatty tissues. Fatty tissues usually help in only storage and releasing them slowly. So lean body mass is very important. So drugs which are can be classified into drugs, lipophilic drugs and hydrophilic drugs, water soluble or liposoluble. And so the formula or the descriptions that we have to use for selecting the drug dosage: one is the total body dose or total weight, ideal body weight, which earlier I told you that it is the height in centimeters minus 100 for men and 105 for female. But the actual formula is this is the one, which is the 45.4 plus 0.89 multiplied by height in centimeters minus 152.4 plus 4.5 if male. And but this will roughly come to the easy calculation of height minus 100 and 105. Then there is another terminology called adjusted body weight, which is a correction factor used, but this is not commonly used. But this lean body weight is very, very important. And there is a separate formula which is used by Jamieson and other people. Male, female, there is a small difference. The top column is the same, with the bottom changes, and the body surface area. Some drugs can be classified when given or administered according to the body surface area, and the formula for calculating that is square root of height into total body weight divided by 336%. And this picture shows how the composition of fat and lean body mass varies in a normal weight person. It is about 80-20. This 4 is to 1. Whereas in a obese patient, it becomes 60-40, which is the ratio of 3:2. So more fat will be there, lean body mass will come down. So based on that, we classify the drugs into lipid soluble and water soluble. The difference is whenever you have lipid soluble, the volume of distribution is more because the fat is ubiquitously present all over, and limited volume of distribution in water soluble drugs. Large loading dose will be required because most of the drug will go into the plasma, and the initial concentration will sharply fall, and those based on actual body weight in cases which are highly lipid soluble, whereas you can do it on ideal body weight if it is water soluble drug. So examples of highly lipid soluble drugs are pipentone, propofol, fentanyl, dexmedetomidine, diazepam, midazolam. Weakly lipid soluble drugs are vitamin and morphine. So based on that, this is how you calculate total body weight based drugs like propofol. For initial loading dose, it should be on total lean body weight. But maintenance dose of propofol, if you are using PIVA, it should be on total body weight. So many microgram or milligram per kilogram body weight should be the maintenance dose. But loading dose should be only on lean body weight. Similarly, the lean body weight is used for peptidone, vicronium, tetracycline, nocronium, etc. And total body weight is taken for midazolam, hexametonium, and the initial bolus doses of citracurium, etc. and pancronium. Vascular access can be challenging, and you have to use shuttle line if it is peripheral veins are not available. Volume replacement, you go it on lean body weight, not on total body weight. Don't do any rapid fluid administration in obese patients because that will the vascular compartment will not be able to take it. Now coming to the challenges in anesthesia for obesity, this is a mnemonic form to remember it very easily. The Prime Minister at a public function. So here you first and foremost, importance is given to airway and positioning, monitors, agents use, technique use, weight relief, and fluids. So the airway, do a detailed evaluation. Planning is essential, including plan for awake fiber optic intubation. Positioning, head up during induction, ramp position, and recovery also. Try to keep the patient at least 30 to 40 degrees head up, and positioning for surgery is also very important. If you can improve in that. So for intubation and recovery, your normal head up position. But for surgeries, especially robotic, you will need abnormal positions like feet and doing well, which have to be taken care of. Monitors, you have already seen how to do all the monitoring. Agents, you can use the drug dosing is very important. Calculate how much to give. If you are using volatile anesthetic, the staurin will be a drug of choice, especially scenarios where you may get a scenario where a obese patient comes for bariatric surgery as a plan for weight reduction. So in that situation, what is the recommended technique for bariatric anesthesia? The use of volatile alone or some other IV agents also. Current recommendation of maintenance or intraoperative management for bariatric surgery.
IV
They
agents.
recommend
IV agents also.
IV propofol. The recommended technique they have found more successful is intravenous infusion of ketamine at doses of 0.1 milligram per kg body weight and dexmedetomidine again 0.1 microgram per kg body weight as an IV infusion plus desflurane as a volatile anesthetic. This has been the technique of choice for bariatric surgery, from which patients recover nicely without any pain and at the same time without any residual effects of these drugs. And the technique, what we have to follow is for, and if regional anesthesia is planned, you must always have a alternate plan for general anesthesia. And pain relief, you use as minimal narcotics as possible, especially if the patient is suffering from OSA, and go for multimodal anesthesia. What we have mentioned about facial plane blocks and even epidural will be a very challenging thing to these patients. So facial plane blocks are much more difficult because of the overflowing fat on the flank and abdomen. So doing a rectal shield block itself can be under open, they can do it with open surgery, but doing it under is also quite a challenging task. And the fluid replacement, you have to remember about the replacement using the body weight and avoid that. So these are all the points that I would just like to share with you. This particular topic. Okay. Right. Well done, Priya.
Thank you.
Nicely mentioned